Good afternoon, everyone. Thank you for bearing with us to ensure that all our panelists were able to attend this important briefing today. I'd like to say thank you for joining us today for the Marburg virus disease briefing, part of the Virginia Public Health webinar series for Virginia hospital and health systems. Today is October the 23rd, 2024. My name is Robert Hawkins, Director of Emergency Preparedness with the Virginia Hospital and Healthcare Association. A few housekeeping items before we begin. All lines will remain muted throughout the duration of today's webinar. If you are connected by phone for your audio, please also ensure that you're muted on your end. If you have questions for the panelists today, please type them in the chat box. We'll host a brief Q&A session following the presentations. The slides and recording of today's webinar will be emailed out to all registrants this afternoon. On behalf of the Virginia Hospital and Healthcare Association, I would like to introduce our colleague from the Virginia Department of Health, James Moss, State Hospital Coordinator from the Office of Emergency Preparedness, who will kick off today's meeting. James?
Thank you, Robert, and thank you to VHHA for hosting and your continued partnership. Good afternoon, everyone, and again, thank you for joining us today. The Virginia Department of Health wanted to provide an opportunity to brief our hospital partners on the current Marburg virus disease outbreak in Rwanda. As Robert mentioned, if you have any questions throughout the duration of the presentation, please feel free to utilize the chat, as we have a number of subject matter experts online that can address that in real time, or as mentioned, we will have a brief moment at the end to address any questions as well. I'd now like to introduce the VDH Office of Epidemiology Director and State Epidemiologist, Dr. Lori Furlano. Dr. Furlano?
Hi, James. Can you confirm that you can hear me?
Yes, we can.
Great, thanks. Welcome, everyone. Today, we're going to provide some basic information, a brief summary about what's happening abroad, describe the domestic response, and then outline some key recommendations. So to level set everyone on some fast facts, there's more detailed information on CDC and VDH's website. Marburg virus disease, or MVD, it is a rare but severe hemorrhagic fever. It's similar to Ebola. It can cause serious illness and death. The reservoir host of the virus is the African fruit bat. People can become infected with Marburg when they come into close contact with these bats. And then the virus can then spread between people via direct contact through broken skin or mucous membranes, with blood, secretions, other bodily fluids of infected people, or with surfaces and materials that have been contaminated with these fluids. The virus can also spread via semen from men who have recovered. Other potential exposures could include things like burial ceremonies or similar activities. The incubation period varies from 2 to 21 days. The illness begins abruptly with high fever, severe headache, severe malaise, watery diarrhea, abdominal pain, cramping, nausea, and vomiting can begin later on the 3rd day after symptom onset. Not all cases present with hemorrhagic signs, but severe hemorrhagic manifestations may appear between 5 to 7 days after symptom onset, and the fatal cases usually do have some form of bleeding, often from multiple areas. Testing is available at many laboratory response network lab, including our own here in DCLS, CDC, and also at 13 regional special pathogen treatment centers, which are positioned around the country. In Region 3, we have 2, Johns Hopkins University and MedStar. The testing itself is available at Johns Hopkins. It's not yet available, but my understanding is being currently validated at the MedStar facility. There are no FDA-approved treatments or vaccines. Next slide, please. The virus was first recognized in the 60s. There were simultaneous outbreaks among laboratory workers in Frankfurt, Germany, and Serbia, and they were working with some infected monkeys that had been imported from Uganda. And since then, outbreaks have occurred sporadically, mostly in sub-Saharan African countries, as shown on the map. Next slide. Moving to the current situational summary, on September 27th, the Republic of Rwanda's Ministry of Health announced its first ever Marburg outbreak. A few days later, they had confirmed 26 cases, including 8 deaths, and they were reported from 7 of the 30 districts in the country. Notably, most cases were in healthcare providers working at 2 particular facilities in the capital. As of October 21st, there have been 62 cases that have been identified, including 15 deaths, resulting in a case fatality ratio of approximately 24%. At least as of last night, there have been no new cases since October 13th. The vast majority of the cases have been reported from 3 districts within the capital, and there's no evidence of widespread community transmission at this time. I do want to reiterate that over 80% of the confirmed cases in Rwanda are in healthcare workers from these particular healthcare facilities. They have initiated contact tracing, which is underway. Exit screening is being conducted for persons who leave the country, and they've also begun vaccinating close contacts of patients and healthcare workers with an experimental vaccine. Currently, there are no cases in the United States, and the risk to the general public in the United States is low. Next slide. CDC and other federal partners have been taking steps to support this response and also to prepare domestically in the event there would be an imported case. On the slide, there's a summary of some key actions, including travel health notices, a health alert network advisory for clinicians and public health officials, and some issuance of interim recommendations, for example, for the public health management of US-based healthcare workers that are returning, and some post-arrival public health management guidance for travelers from Rwanda. And there's more detail, and these links, once the slides are sent out, are clickable and you can get to what you need. Next slide. Here in Virginia, we have established an incident command structure to coordinate our activities. We're attempting to raise awareness of this outbreak in Rwanda by sharing information with partners like you. We're training our staff. Educational efforts do include updating and maintaining our public-facing website that just went live a couple of days ago. We issued a clinician letter earlier this month, and we'll continue with opportunities like this webinar today and further clinical updates as those become necessary. VDH is screening, monitoring, and providing education to travelers who recently entered Virginia from Rwanda. That'll be described in the subsequent slides. We're working internally to update plans and guidance and procedures for those of our team that are conducting surveillance, traveler monitoring, and working with all of you on healthcare coordination and preparing for possible case. We are actively engaging our partners. We're grateful for our laboratory partners, including DCLS. Something went wrong. Excuse me. The hospital. Hospitals designated to assess or treat the patients, our partners, the federal government, the international airport, and our local health districts. Next slide. I'm going to move on to traveler screening and monitoring. You can advance the slides. As I mentioned earlier, Rwanda is conducting exit screening. There are no direct flights from Rwanda to the United States. To further reduce the risk of Marburg being introduced into the U.S., starting on October 16th, the U.S. government began redirecting travelers who had been in Rwanda in the last 21 days into 3 select airports, which are listed on the screen, one of which is Dulles Airport in Northern Virginia. These airports were selected because they typically receive the greatest number of travelers from Rwanda. Historically, about 120 travelers from Rwanda enter the U.S. daily, and these are average statistics, but Dulles specifically receives about 20% of those travelers. We have some preliminary information that the number of travelers has reduced a little bit, but time will tell as that trend, we'll watch that trend closely. Next slide. Upon arrival into the United States, travelers from Rwanda will be directed to a particular area of the airport that has been set aside for public health screening, where the CDC will confirm that person's contact information. They will be observed for signs of illness, and their temperature will be measured. They will also be asked about their health and any potential exposures. Travelers with an elevated risk of exposure or travelers who appear ill will be referred to another evaluation. All travelers will be enrolled into a CDC automatic health text messaging. So the intent of that CDC text messaging campaign is really to push out informational or educational messages to travelers during the monitoring period. And our understanding is that all travelers, regardless of their risk of exposure, will be receiving those messages. For a subset of the screened travelers, CDC will recommend public health monitoring by health departments. So CDC is going to share that information with state health departments for the traveler's final destination. So for travelers that have Virginia as their final destination, will be receiving that information. If they're passing through Virginia and moving on, say, to Colorado, Colorado will receive that information. Next slide. We have established our traveler monitoring program, or reestablished, I should say, to monitor travelers from Rwanda for those whose final destination is Virginia for 21 days since leaving Rwanda. I do want to note that VDH does have some experience in traveler monitoring. We've done this a handful of times in the past for different outbreak responses, and we've been able to refine and adjust and improve our processes over the last decade. In general, the way this process works is that CDC shares electronic information with VDH on a daily basis for these particular travelers that are recommended for monitoring. The VDH staff, this happens locally, call each traveler ideally within 24 hours of their arrival. Our team conducts an initial health assessment. We ask detailed questions to identify and assess any potential exposures that the person may have had. And we make sure that the person doesn't have any current symptoms consistent with Marburg. Then the local health staff talk about expectations for the 21-day period, how the person will be monitored, what to do if they develop symptoms, for example, to contact their local health department at a particular phone number. And our staff will classify that traveler's exposure risk into one of 4 categories, which I'll detail in a couple of minutes. We are also going to offer to mail them a thermometer and an at-home self-administered COVID and flu test kit. Then our team will thank you to the local health departments for taking all of this on. They will check in for the remainder of that 21-day monitoring period using a combination of automated texts or emails. And the frequency of those check-ins will depend on the traveler's exposure risk. If the person develops symptoms, the local health district staff will then work to refer that traveler to a facility for evaluation. There'll be extensive coordination with that healthcare facility if we're made aware ahead of time, and we would coordinate with clinicians as needed, coordinate with the laboratory, etc. Next slide. So we mentioned that VDH staff is going to assess and classify the exposure risk for each traveler. So this is kind of a double confirmation of the information that CDC has collected at the point of entry into the country. So this slide provides more details on our process. So to orient you, the columns in this table are the 5 different risk categories that VDH is using from left to right: high, then there's 2 medium categories, one for healthcare personnel, one for non-healthcare personnel, some risk and low risk. VDH created the labels in this table. These are not terms you're going to see in CDC guidance, but they are aligned with CDC framework. The table summarizes any movement restrictions, whether or not the healthcare worker needs to be excluded from work, and then the frequency with which our VDH staff will check in with the traveler. I do want to note that this is assuming that the person under monitoring does not develop any symptoms. Anyone who develops symptoms will kind of go into a different pathway and will be instructed to contact their local health department immediately. For purposes of this guidance, healthcare for facilities includes hospitals, outpatient settings, and traditional healers. High risk, so that first left-hand, well, I guess it's the second left-hand column, but high risk means that CDC high risk exposure definition has been met. So as an example, this could be someone who had a percutaneous exposure to blood or body fluids from someone with known or suspected Marburg, could be someone who had direct contact with a person with known or suspected Marburg, or someone who provided health care to a person with known or suspected Marburg and did not wear the recommended PPE. There are a couple other scenarios in that category. Medium risk, if you're a healthcare worker, it means that you were present in a Rwandan healthcare facility in any area of that facility and in any capacity. If you are not a healthcare person, you would be in medium risk if you were present in a Rwandan healthcare facility in a patient care area. For example, if you were a visitor or you yourself were receiving care in a healthcare facility. Some risk means that the person was in Rwanda. They didn't meet an exposure in the other categories, but had some other kind of exposure. So for example, if the person attended a funeral or a burial, that's one of several examples in that category. Low risk means that the person was in Rwanda, but did not enter a healthcare facility and did not have any of the other types of exposures. You'll see in that row labeled movement restrictions, there are different restrictions in place depending on the level of risk delineated. High risk is really the only group with true movement restrictions in that they must quarantine at home during their monitoring period. They can telework virtually, but they are really not allowed to leave their home. All other group categories can perform routine activities. They can go to work. There's some exceptions here for healthcare workers, which I'll get into. Healthcare workers who are in high or medium risk groups are recommended to be excluded from work duties. So that includes clinical work duties and non-clinical work duties for the entire 21 days of their monitoring period. CDC does have an exception in place for certain healthcare workers who traveled with specific groups. An example is Doctors Without Borders. They worked only in Marburg treatment units, and they had no high-risk exposures. Those healthcare workers are allowed to continue working. It's a little bit of a complex recommendation, so I encourage you to review in detail on the CDC website. All of our travelers are advised to self-assess for symptoms every day, take their temperature twice daily. And the frequency with which our team will check in is also on the slide, and it varies on the person's risk category. For high and medium risk, we will be doing daily check-ins. Next slide. To protect the traveler's confidentiality, VDH does not plan to share details about travelers under monitoring in Virginia. This is consistent with the Code of Virginia, our regulations, and confidentiality policies. If or when a person develops symptoms and medical evaluation is needed, we will certainly communicate the information that's needed with relevant healthcare partners. And we will share aggregate data about the number of persons we have in our monitoring, et cetera, but personal details will not be shared. Gonna switch gears, the next slide. I think I'm gonna hand it over to James for a couple slides to talk about the framework of the kind of the treatment system of care. Thanks.
Thank you, Dr. Furlano. Matt, next slide. First, we would like to set the stage by revisiting the tiered system for hospital preparedness that was originally established back in the 2014-2016 Ebola outbreak in West Africa, and subsequently has been updated by the National Special Pathogen System, or NSPS. With this tiered system, there's an acknowledgement that caring for patients with Marburg virus disease and Ebola is complex, and there's a lot of variation in capacity across hospital systems, not only within the Commonwealth, but throughout the nation. To align more closely with the trauma burn systems, the NSPS is organized by levels and descriptors of the system of care facilities. The NSPS system of care provides care via a tiered healthcare system ranging from specialized care facilities to those focused on identification of suspect cases and coordination of movement within the network. The main type of facilities, starting from the bottom, are level 4 facilities. These are all healthcare facilities previously referred to as frontline facilities. These make up the majority of healthcare facilities in the Commonwealth and throughout the U.S., and these facilities should be prepared to promptly identify, isolate, and initiate stabilization practices and arrange for timely management for patient transfer. Next is level 3, and these were previously referred to as assessment facilities. Level 3 facilities are widely accessible care delivery facilities able to conduct limited basic laboratory testing and stabilization and coordinate rapid patient transfer to minimize impacts to normal facility operations. Next is level 2, and these were previously referred to as state treatment centers, facilities. This is a special pathogen treatment centers at the state level. Level 2 facilities are hospitals that have the capacity to deliver specialized care to clusters of patients suspected of or infected with a special pathogen and serve as a primary patient care delivery center. Virginia is very fortunate to have 2 of these facilities in the state. UVA Medical Center in Charlottesville and VCU Health in Richmond both serve as level 2 treatment centers. And finally, at the top of the tier are level 1 facilities, and these are regional special pathogen treatment facilities, or RESPECs. Each of the 10 Health and Human Services region have at least one of these facilities, and in Region 3, we are very fortunate to have 2. Johns Hopkins Hospital in Baltimore and MedStar Washington Hospital in Washington, D.C. serve as these centers for Region 3, which cover Virginia, Delaware, D.C., Maryland, Pennsylvania, and West Virginia. Next slide, please. This slide provides a high-level overview of what is currently drafted for levels 1, 2, and 3 to date. I won't belabor this slide, but wanted to provide additional information and context for what NSPS is considering and the likely operational elements associated with each level. And I'll call special attention to care duration, capacity for viral hemorrhagic fever, and laboratory testing ability. Next slide. All healthcare facilities in Virginia should be prepared to follow the 4 I's that are shown on this slide. Identify, isolate, inform, and initiate. Identify means promptly identifying a patient with suspect Marburg virus disease based on the patient's exposure history and symptoms. If a suspect case is identified, then the patient should be isolated in a private room with private bathroom. Providers caring for this patient should use the recommended PPE, limit the number of healthcare personnel in the room, perform only the necessary testing, and avoid aerosolized generating procedures, and follow waste management recommendations for Class A infectious substances. They should also immediately inform the facility's infectious disease staff and their local health department, and they should initiate stabilizing medical treatment. And I'll turn it back to Dr. Furlano to discuss the management of a suspect patient.
Thank you. You can go to the next slide. I'm going to walk through some of the, you can advance, thanks. Go through some of the main steps, thank you, and considerations at each step. So starting from the top, this is when a suspected case is reported to VDH, and that can happen in a variety of ways. It can come from a clinician at a healthcare facility. A local health department may have received a call from a traveler, or a local healthcare provider has someone in their facility who didn't call ahead of time, etc. Or the port health station at the airport may give us a call if there's an ill traveler who perhaps has just landed. For the airport situations, the port health station staff will be communicating with both the CDC headquarters in Atlanta as well as our VDH staff, and that's a collaborative process to determine if the person should be referred. CDC ultimately kind of makes that determination, particularly if the person is acutely ill. Then if that's needed, the Washington Airport Authority's EMS will transport that traveler by ambulance to a predetermined facility. We'll also be coordinating with the infection control team at that receiving hospital as soon as that decision is made. Next slide. For some situations, VDH staff at the local health departments and the central office will quickly gather available information about the person's signs and symptoms and epidemiologic risk factors to determine if a person meets CDC's suspect case criteria. Clinicians at a local healthcare facility are encouraged to use the CDC special pathogen evaluation algorithm that'll be shown on a future slide. If a suspect case is identified, the facility should immediately contact its infection control team and the local health department if that contact has not already been made. A key piece of information at this point really is the location of the patient. So have they already presented to a facility? What kind of facility? So where do they fall in that tiered framework that James just presented? If they haven't yet presented to healthcare, we work through questions about how to get them there, where they should go, what the best location is, and what kind of evaluation they might need. Next slide. This slide is a screenshot of a one-page evaluation algorithm. It does have some links within. This is from CDC. It's intended for a hospital healthcare audience to take you through high-level key steps, things like asking about travel history, symptoms, epidemiologic risk factors, and if Marburg is suspected, what kind of infection control practices and PPE would be recommended and who to notify. This is just a reminder of where you can find this. It is posted on our website and also on the CDC website. Next slide. So the third step, if we get to a point where we believe that together with a treating clinician, we believe that the patient would warrant testing, we would call CDC kind of in partnership with the Division of Consolidated Laboratory Services to get approval for the testing. DCLS conducts that initial testing for Marburg virus. The CDC is available 24/7. They're very prompt in getting back to us, and we usually get a call back within 30 minutes, if not sooner. Next slide. Thanks. If CDC approves the testing, we would quickly convene staff from the healthcare facility, local public health, the laboratory to share any information collaboratively to make sure we all have the same information at that point in time. We would want information on the patient's clinical status, epi risk factors, any needed logistical discussions, and communications needs. Key topics would involve immediate next steps, ensuring that clinicians understand specimen collection, whether or not the person would need to be transferred to a different facility, and risk communication. We will also be in communication at this point with our Virginia treatment centers, but also the regional special pathogen treatment centers that James was describing to make sure everybody has situational awareness and to plan for the possibility of transferring the patient if that is necessary. Next slide. The next step involves collecting and packaging specimens and getting them to DCLS for testing. I think was mentioned earlier, I believe we mentioned this earlier, the lab will be pre-positioning some Marburg specimen collection kits at specific hospitals. For example, those that coordinate with the airport health station and some of our local health districts. DCLS has very detailed instructions for collection and handling that are linked on this slide, and I believe at the end of the slide deck for reference. In brief, multiple specimen types are needed, 2 whole blood specimens in plastic EDTA tubes, plus 1 nasopharyngeal or nasal swab in viral transport media. There's some other, I'm not going to read it all, but there's some other specimens. They have to be triple packaged by staff who are certified in Category A packaging. So I encourage you to have relevant members of your team to review these specimen collection guidelines ahead of time. DCLS has the capacity and will dispatch an emergency courier to retrieve these specimens, but there will need to be very real-time coordination and communication to make that we appropriately time the dispatch of that emergency courier. Once the specimens are received at DCLS, the test results for Marburg should be available within 2 to 3 hours. The timing of when the specimen is collected is important. given the sensitivity of the Marburg virus test result, if a specimen was collected less than 72 hours of the person's symptom onset and the test is negative, then a new specimen will need to be collected and tested after 72 hours of onset before Marburg can be ruled out. Please note that DCLS positive and negative results are both considered presumptive. CDC does the confirmatory testing regardless of the initial result at DCLS. There's links to DCLS guidance on the slide. Next slide. So following results will depend on the results, or following steps rather will depend on the results from DCLS testing. If DCLS detects Marburg, that's considered a presumptive positive. CDC will perform confirmatory testing, but further steps will be quickly initiated. So this will be reassessing if the patient needs to be transferred, if they aren't already in a treatment facility. There's going to be a lot of communications amongst partners, including public information officers, our Secretary of Health, Governor's Office, etc. That'll all be happening on the epi side of things. Our team locally with state support would also start contact tracing efforts to identify anyone potentially exposed in either community or healthcare settings. Specifically for the healthcare setting, this will be a shared responsibility between VDH and the impacted facility, where the facility would be expected to identify and monitor any exposed healthcare personnel and inpatients, and VDH would cover any exposed visitors or people who have been discharged from the facility. If DCLS does not detect Marburg virus, CDC will still conduct confirmatory testing. DCLS will also start testing for other pathogens, first malaria, then COVID-19, influenza. If the original blood specimen for Marburg was collected less than 72 hours of symptom onset, as I mentioned earlier, specimens would need to be collected later in the person's clinical course. Next slide. Just a really quick oversimplified note on the clinical management of a patient with suspected Marburg virus disease. During this process that I just described, when notification and testing is happening, it's important that clinical management and stabilization of the patient should proceed as is indicated by the person's clinical status. The early symptoms of Marburg are not specific to Marburg. These are things like fever, headache, weakness, and they're seen in other more common diseases. So evaluation and treatment, if that is indicated for these other causes, should proceed while we're waiting for Marburg test results. It's very important not to miss a treatable condition and have the patient destabilized while you're waiting for Marburg virus testing to result. Malaria is the most common cause of undifferentiated fever after travel to sub-Saharan Africa. Malaria can progress rapidly, so early diagnosis and treatment is key to survival, and malaria testing should not be delayed. CDC does have some specific information that's linked here on their website about how to modify thick and thin smears that are used for malaria diagnosis in a patient with suspected Marburg. If you need assistance with the diagnosis or management of suspect cases of malaria, we can connect you with the CDC Emergency Operations Center, and we can request to speak with subject matter experts on malaria. Next slide. And you can proceed, please. Thanks. Early identification of Marburg and other viral hemorrhagic fevers is important to provide appropriate and prompt patient care and also to help us prevent the spread of infection. So healthcare facilities are encouraged to ensure that they have triage and evaluation processes well established to identify these patients with compatible symptoms and risk factors and exposure risks. If a person with relevant exposure history and relevant signs and symptoms, they should be immediately isolated, and infection prevention and control procedures should be implemented. Obviously, the IP program or other relevant staff and your local health department should also be notified immediately. Next slide. Travel history is incredibly important. It's important for this condition and many others, it's important to obtain a thorough travel history for all acutely ill patients to identify whether they have epi-compatible risk factors within that 21-day period prior to their symptom onset. So questions like, have you been to a country with a Marburg virus disease outbreak in the past 21 days? This is probably a good time to note, at least as of right now, our understanding is CDC is applying all of these recommendations to the entire country of Rwanda. In prior responses, they've been a little bit more targeted in naming specific geographic areas. So I do want to note that is currently the situation, but also subject to change. And you can see the other questions that are helpful to know to ascertain exposure risk on the screen. Next slide. This slide describes some infection control for suspect cases, including isolation recommendations, guidance around necessary tests and procedures. There are environmental cleaning guidance documents and waste management guidance that CDC puts out. So relevant staff at healthcare facilities that may be receiving these patients should brush up on those environmental cleaning and waste management guidance documents. Next slide. Choosing PPE requirements depend on whether a patient is clinically stable and suspected to have MVD, so has no bleeding, vomiting, diarrhea, or is confirmed to have a viral hemorrhagic fever suspected with obvious bleeding, vomiting, or diarrhea. So clinically stable versus clinically unstable. We want to ensure the correct selection of the PPE, having comprehensive training and competency established prior to these situations is critically important, including on-site supervision, trained observers, etc. Developing exposure management plans for potential exposures is a helpful resource ahead of time. And again, we can connect facilities. I'm sure James has resources as well to training and resources around infection prevention and control. On the next slide lists some key resources, and there are several that have gone live this week on our website. Please, thank you for staying connected with CDC and VDH updates. You can enroll in CDC's Health Alert Network. You can also register to get our monthly newsletter. And knowing how to contact your local health department, including their after-hours information, is a great local resource. And there's also some other websites on here that can help you stay up to date. Next slide. Just want to leave you with some take-home messages. This is a severe disease, but it is rare. There is ongoing work to contain the current outbreak in Rwanda. There are no cases in the United States. The risk of infection is considered low. People entering the United States are being funneled to 3 airports, and Dulles is one of those. We will be monitoring certain travelers who have been in Rwanda in the last 3 weeks. We expect the numbers probably to be lower than they have in prior responses. That's for a variety of reasons, but we will continue to provide partners updates as those become available. And in summary, Virginia facilities and clinicians should be prepared to promptly identify, isolate, inform, and initiate stabilizing care. And a reminder again that travel history is very, very important in identifying this condition. So thank you for your partnership. I think that's the end of our slides today. And my understanding is that we might have some time for questions.
Thank you, Dr. Furlano, and the entire VDH team for providing this content for us today. You are correct. We have a few questions already in the queue, but we also have some additional time at this point for questions. So please submit any questions for the presenters or panelists that you may have in the chat box, the Q&A feature. We're going to pause for a few moments to allow for submission of questions and allow the panelists to review the questions that have been submitted and provide some answers. While we wait, I'll go ahead and pose the questions that are in the queue currently so our panelists can unmute and answer these questions if you'd like. One question: what will hospitals receiving a patient by EMS be expected to provide the EMS team to decon themselves or their unit?
Hi, this is Katie Kirkchin with the Virginia Department of Health. As Dr. Furlano covered, list Q disinfectants would be needed for a lot of the cleaning and disinfection, and there are some great resources from NETEC specifically for EMS. I haven't seen anything from CDC yet, but I know VDH's Office of Emergency Medical Services also has a website with some information available on that. Thanks.
Thank you for that response. The next question is, how much time will hospitals receiving a patient have when they've been instructed by VDH to seek medical treatment, and how much time would they have before a patient arrives?
This is Laurie. Laurie Furlano. I can try to start the answer to that. I think it depends on the patient and the clinical status of the patient, but the short answer is I think that would be a top priority. So as soon as we are aware of a patient or a person at home, for example, with symptoms, and we've determined that they need to be seen in a healthcare facility, that would be a #1 priority of the local health department staff to make sure that receiving facility knows that the patient is arriving. If it's possible to time that, we certainly can, but it would depend on the person's clinical status.
Thank you for that answer. The next question is, will a patient in an assessment hospital be cared for until the CDC confirms a positive test, and how long would that take?
I can answer the turnaround time of the testing. If James, maybe you can chime in on the expectations of length of care. So CDC I will say DCLS will first provide the presumptive result. So for example, if it's positive, we would act on that. And CDC, upon receipt, I don't know if anyone from the lab is on, but I believe their time frame would be similar. So within 2 to 3 hours upon receipt of that specimen, I think they would be able to confirm. But obviously there's travel time to get it there.
And for the duration of the care for our assessment centers, which are level 3 facilities, the general time frame is 12 to 36 hours. Obviously, that is dependent on the circumstances that are presented at the time. Our level 2 facilities is for the duration of illness, and level 4, which are those frontline facilities, it's as rapidly as we can work them through the process to get them transferred to the next level of care.
Thank you both for that answer. The next question is, should EMS begin travel screening questions now?
That is something we can work with the Office of EMS to coordinate with. As Dr. Furlano noted, that we don't have any known or haven't received any patients yet. So when that situation presents itself, we can provide recommendations to the EMS councils and they to their members regarding that. Unless Dr. Furlano or Katie, you have anything else to add?
No, agree that we'll work out that guidance. Persons will, when we do intake of travelers and that point of contact, we can also work to make sure they understand if they do have a need to say call 111 for an urgent medical emergency, that we'd recommend they communicate their exposure risk to those EMS providers. But we'll work out other coordination between agencies on a need-to-know basis.
Thank you. And a similar question, is it recommended for healthcare facilities, including level 4 facilities, to conduct travel screenings at this time?
Hello, hey, it's Carolyn Kiefer from Virginia Department of Health. And as of the October 3rd Health Alert Network, CDC does recommend that clinicians do begin that exposure risk screening along with that travel history.
Great, thank you for that. Next question is, any insight into why a majority of MVD deaths in Rwanda are healthcare providers?
I can start, and Katie, maybe you can chime in here. So I think part of that is good news, is that there's no evidence of widespread community transmission in Rwanda. And I do think I believe, if my memory serves me correctly, there have been no new cases in the last 10 days. I don't know if that changed today. So I think that trend is improving, in that they have established, some infection control in these facilities. It's possible that the proper levels of infection control were in place prior to, kind of having knowledge that the outbreak was in existence. I don't know, Katie, if you have more knowledge there.
This is Katie from Virginia Department of Health. I don't know specific details of why there is spread among these two particular healthcare systems and in the capital. I mean, the Rwandan Ministry of Health and has kind of emphasized this is really a nosocomial or HAI related outbreak, but I don't know the details on where the gaps have been on infection prevention and control. Thanks.
Thank you for those answers. I think we have just a few more questions. If there are members of the community at high risk under monitoring that require hospital level attention, would attempts be made to get them to an assessment center instead of a frontline hospital?
And this is James. I think the short answer is yes. If we have the knowledge and awareness that they are experiencing more acute signs and symptoms of this, ideally we would like to get them to a higher level of care to avoid the additional burden of transferring and transporting that individual to another facility after they've already gone to the initial healthcare facility.
Thank you, James. And one additional follow-up to that line of questioning, would frontline hospitals be expected to collect testing samples, or would patients be transferred to an assessment hospital for that stage?
Generally, that would be one of the higher levels of care, level 1, 2, or 3. Obviously, it is somewhat situationally dependent, depending on their acuity and symptoms. But generally, the intent would be to get them to a higher level of care that has the necessary precautions and preparedness efforts in line to be able to more safely be able to do that.
Thank you. Are there any more questions for the Q&A? All right, seeing none at this time, I just want to provide the reminder that the slides in the webinar recording will be provided to all registrants later today. It looks like we do have a new question. Is there a list of available Virginia hospitals and what level they are?
We do maintain that list internally. It's not one that we publicly share. If you do have a specific question, you can feel free to reach out to myself. I'm happy to share that information, but it's not something that we typically have available for the public. So please feel free to reach out to me. And likewise, if there's a facility that is interested in being more than a level 4 frontline facility, please feel free to reach out to myself or Robert Hawkins at VHHA. We do administer the VHIM program for the state and are happy to have those initial conversations with you if you are interested in being one of those higher tier facilities.
Thank you, James. And this is probably also a question for you. Would a transfer to an assessment hospital be by specialized providers or local EMS?
Generally, it would be a pre-identified EMS agency that does have the capabilities and kind of knowledge of that. However, there may be a circumstance where that may not be the case. And so ideally, it would be one of the pre-identified EMS agencies, but there may be an isolated situation where it could be a local EMS entity.
Thank you, James. There are no more questions to queue. In the interest of time, we're going to go ahead and begin conclusion for today. I just want to express our gratitude for the panelists and presenters for the very valuable information they've shared with us. I want to thank everyone for attending and joining us today for this webinar and receiving this information. And at this time, this will conclude our webinar for today. Everyone have a wonderful day.